Hello, Dr. Montgomery. My name is Duncan Andrus, and I'm a pharmacy student. I'm here to talk about patient Savannah Nevin, age 31. Her date of birth is 8/28/93, and it's my understanding that you would like some recommendations in regards to the patient's pregnancy status and her medications. Mrs. Nevin is a 31-year-old female with a chief complaint of, I have not been feeling so well these last couple of weeks. I've been nauseated, tired, irritable, and my breasts are really sore. I wondered if I was getting my period, but I normally don't get nauseated, and this month I missed my period. I decided to take a pregnancy test, and it was positive. I'm very excited, but worried that the medications I am taking may be harmful to my baby. She presents reporting some nausea in the morning, accompanied by vomiting. The GI symptoms started about 2 weeks ago and have remained consistent since. She did state that she feels pretty run down all the time, and she was prescribed an antidepressant 3 years ago and states that she's currently stable and hasn't tried to wean off that medication at all. This leads us to her past medical history of depression, hypothyroidism, and migraine headaches. Her last menstrual period was 7 weeks ago, and labs that are pertinent include a negative COVID test, a negative urine analysis, and a positive beta HCG. Her hematocrit and hemoglobin are also slightly low, and her CO2 is slightly elevated. All of her other labs are within normal limits. All of her vitals are normal, and then her family history that's pertinent includes a dad and a sister with depression, and then a sister with Hashimoto's disease. Her pertinent social history includes the patient works as a physical therapist. She exercises 3 to 4 times weekly, as well as she goes on walks with her dog every day, and she has never used tobacco, but does report occasional glass of wine or alcoholic beverages on the weekends. The patient's current medication list is just 3 medications. It's paroxetine 20 milligrams, 1 tablet by mouth daily, levothyroxine 88 micrograms, 1 tablet by mouth daily, and a naratriptan 2.5 milligrams at the start of migraine that she can repeat after 4 hours at a max dose of 5 milligrams in 24 hours. The patient's primary problem is pregnancy with some comorbid conditions or some pre-existing conditions. The patient presented with nausea and vomiting for the last 2 weeks, and her low hematocrit and hemoglobin are low, which could indicate anemia, which is commonly associated with pregnancy. Her elevated CO2 is also consistent with the increased metabolic rate that we see in pregnancy, and her positive beta HCG just kind of further rules in that pregnancy, and she also had a positive pregnancy test at home. She has several comorbid conditions or pre-existing conditions that she's being treated for, and is currently taking 3 medications for that. Some short-term goals for this patient is to prevent side effects of medications, manage some other symptoms of nausea and vomiting, ensure the patient has access to proper resources, and to safely change therapy to pregnancy-safe medications. And then some long-term goals is to prevent birth defects and to keep the mother and baby healthy throughout the pregnancy. So the first medication to evaluate is the paroxetine, which is not recommended in pregnancy since it can cause some septal wall defects in the fetus and has been associated with persistent pulmonary hypertension in newborns, as well as an increased risk of postpartum hemorrhage. That being said, there are some safe options for treatment of depression in pregnancy, and is recommended by treating for two, that's part of the CDC, to treat depression in pregnancy. Since she is on an SSRI, switching to another SSRI is ideal to kind of prevent some of those symptoms of discontinuing the paroxetine. According to Briggs Pregnancy and Lactation, sertraline is preferred in pregnancy because it has a very low risk of teratogenicity. Drug monographs for the paroxetine and the sertraline both recommend either a direct switch or a cross titration. A direct switch is preferred in this case since it's the first trimester, and that's where most of the risk for the paroxetine use is. So stopping that sooner rather than later is preferred. The direct switch includes stopping the paroxetine now and initiating sertraline at an equivalent or lower dose and titrating back up. Since she was on the 20 milligram of the paroxetine, switching to the sertraline 50 milligram tablet once daily is what I recommend as of right now. And then the next medication on her list is the levothyroxine. The levothyroxine has not been shown to increase the risk of congenital abnormalities or miscarriages. And then normal TSH levels are required for fetal development. So the levothyroxine should be continued at the current dose and monitored appropriately. The last medication that she's currently on is the naratriptan. This is not a preferred agent for migraines in pregnancy because it's associated with birth defects. Sumatriptan, which is in the same class, can be used, but also isn't preferred. So the preferred agent for migraine treatment in pregnancy is acetaminophen, and the lowest effective dose for the shortest amount of time is preferred by Briggs. And then, so the 325 milligrams every 4 to 6 hours as needed for migraine is what I recommend. That therapy can kind of be monitored if the Tylenol is ineffective or the dose is too low. For the patient's nausea and vomiting, pyridoxamine 10 to 25 milligrams every 6 to 8 hours as needed is recommended. That came from an up-to-date article called Nausea and Vomiting in Pregnancy, Treatment and Outcome, as well as some non-pharmacologic strategies like ginger, hydration, or aromatherapy. And then doxylamine can also be added to that pyridoxine if the nausea persists. And then March of Dimes recommends to use prenatal vitamin in pregnancy. Specifically, in this case, we'll want to use a prenatal vitamin containing iron, since her iron levels are pretty low. And then we'll also want that prenatal vitamin to contain folate at a dose of at least 400 micrograms, just to prevent those septal tube defects. As for some follow-up and referral, I'd like to refer the patient to an OB as soon as she can get an appointment. And then she should also follow up every 4 weeks with her OB. And then I'd also like to refer the patient to a dietitian to just talk about some healthy eating habits in pregnancy, as well as to just talk about that alcohol consumption in pregnancy to ensure she's not drinking alcohol throughout the pregnancy. And then some clinical monitoring for this patient. I recommend monitoring a TSH every 4 weeks, and then monitoring weight, height, depression status, some suicidality, behavioral changes, and then a serum sodium every 4 weeks. I'd also like to look at the heart rate, blood pressure, and any evidence of cardiac symptoms every 4 weeks. And then I would also recommend that the patient monitors for some worsening nausea and vomiting, or any mood changes, mood swings, or irritability that could come from these medications. Those are my recommendations. Did you have any questions? Thank you.